I have the pleasure to introduce the forthcoming international figure in gynae oncology and minimal access surgery, inshallah, to be Professor Khaled Gaballah. I knew him from the early years, and he's one of your students, Professor, isn't it? Yes, and younger brothers. He's going to talk to us about the minimally invasive surgery in early cervical cancer, that it should not be the standard of care. Thank you.
Thank you, Dr. Ahmed. It's my pleasure to be here with you. I am Dr. Khaled Gaballah, Assistant Professor of Surgical Oncology at the Oncology Center of Mansoura University. I really don't have any conflict of interest, apart that the thesis of my MD was in laparoscopic radical hysterectomy itself. As we know, there were too many studies supporting the feasibility of the minimally invasive surgery in early stage cervical cancer since the 2000s, with an accepted disease-free and overall survival. It was nearly accepted worldwide that minimally invasive surgery is the standard of care for early stage cervical cancer until March 2018, where we all had the leg trial that emerged in the ASCO conference. The leg trial was a prospective randomized international multi-center non-inferiority phase 3 trial. Its main aim was to have over 90% power to declare the non-inferiority in disease-free survival at 4.5 years, with a margin of 7.2% between the open hysterectomy and the laparoscopic, or the minimally invasive hysterectomy, laparoscopic or robotic. So what happened that after recruiting 319 patients in minimally invasive arm and 312 patients in open surgery arm, the disease-free survival at 4.5 years was 86% in the minimally invasive group and 96.5% in the open surgery group, with a difference more than 10 points. So they concluded that minimally invasive surgery was associated with a lower disease-free survival rate than the open surgery, and also was associated with a lower rate of overall survival. Following the leg trial, multiple trials came supporting the same results. In the same year, Alexander Melamed published a large cohort retrospective study, including about 2,500 women. Half of them were minimally invasive and half were open surgeries. They found that the 4-year mortality was 9.1 among women who underwent minimally invasive surgery and 5.3 among those who underwent open surgery, and this difference was statistically significant. They found also that the adoption of the minimally invasive surgery coincided with a decline in the 4-year relative survival rate per year after the year 2006. And here's the curve showing that the probability of survival is decreasing significantly in a minimally invasive group compared to the open surgery group. Here also the forest plot curve, mainly favoring the open surgery group, mainly in tumor sizes more than 2 centimeters. So also a number of trials followed that. This large Canadian trial, retrospective trial of about 1,000 patients, then adjusted 5-year cumulative incidence of all-cause deaths, cervical cancer deaths, and recurrences were significantly increased in minimally invasive radical hysterectomy group compared with the open group. The minimally invasive radical surgery was also associated with increased risk of death and recurrence compared to open radical hysterectomy in patients mainly with stage 1B disease, but not stage 1A disease. As we see here in these curves, the all-cause deaths, the cervical cancer-specific deaths, and recurrence will all significantly increased in the minimally invasive hysterectomy group compared to the open hysterectomy group. Another large systematic review was published about 2 years ago, concluded a meta-analysis of about 15 observational studies of about 9,500 patients. 49% of them were minimally invasive, 57% were of the 49 were robotic, the other were laparoscopy. The pooled hazard of recurrence or death was 71% higher among the patients who underwent minimally invasive radical hysterectomy compared with those who underwent open surgery. And the hazard of death was 56% higher in a minimally invasive group. So they concluded that minimally invasive was associated with a higher risk of recurrence on death in this trial. As we see here, both forest plot curves favoring the open surgery group than the minimally invasive group. Further smaller trials followed the emerge of the leg trial, like this of the large hospital in Argentina and Buenos Aires. They concluded about 110 patients. They found that the recurrence rate after laparoscopic rectal hysterectomy was 15%, and in tumors less than 2 centimeters was about 12%. The 3-year disease-free survival was 81%. Overall survival at 3 years was about 87%, which is much more less than the open radical hysterectomy. Another Korean trial was published later after author of the leg trial, comparing the laparoscopic and the abdominal radical hysterectomy in early stage cervical cancers. They included about 120 patients. They found that inferior disease-free survival was observed in the laparoscopy group, with significant difference in the pelvic and hematogenous recurrence between the minimally invasive group and the open group. Here you can see from this curve that disease-free survival was significantly impaired in the laparoscopy group, but overall survival didn't much differ between both groups. Also, the local recurrence and the hematogenous spread, the distant recurrence, was also higher in the minimally invasive group. So until today, this is the latest version of NCCN guidelines. We still recommend that the open surgery, open radical hysterectomy, is a standard of care in the cases of early stage cervical cancer, not the minimally invasive type. Also, in the ISGO guidelines, radical surgery are mainly preferred to be also with open technique rather than the minimally invasive technique. So, to speak about the learning curve, which is, I think, the most important point in this lecture, the main criticism for the leg trial was mainly the learning curve due to the heterogeneity of the surgeons from multiple countries. And this was the main point of criticism, that not all the surgeons had the same training ability from the multiple centers worldwide. As you see in the learning curve, the minimum number of several cases required to acquire the necessary surgical skills to do a radical hysterectomy, whether by the open technique or the laparoscopic technique. A nice Korean trial was recorded about this. The medical reports of laparoscopic radical hysterectomy between August 2004 and April 2011 were reviewed retrospectively. The patients were divided in 2 groups, the first 35 cases and second 35 cases. All the operations were done by the same surgeon. And they found in the results that the mean operative time of phase 1 was significantly longer than phase 2. That implicate that the learning curve affect much more the quality of the operation. The number of complications also in phase 1 was significantly higher than phase 2 patients. But the disease-free survival didn't differ between 2 groups. They conclude that the learning period to do competent laparoscopic radical hysterectomy was to be 40 cases, which is really a large number. Another trial comparing between Chinese trial comparing between 100 cases of minimally invasive surgery, comparing between the first 50 cases and second 50 cases, we found that we have significant difference in the operating time, in the hemorrhage, in the time to have a post-void normal residual urine and length of hospital stay, and also was the pelvic node harvest. Following that, earlier this year, a large meta-analysis was published about the learning curve for in the case of radical hysterectomy. It included about 25 studies after doing all the exclusion criteria. We also want to highlight some of these studies. This is a Korean one. There's a retrospective study conducted by Kim et al. In about 90 patients. The learning curve of each type of surgery were obtained, and the minimum numbers of cases required to achieve surgical improvement were found to be about 16 in abdominal hysterectomy, and 13 in laparoscopic radical hysterectomy, and 21 cases in assisted radical hysterectomy. So they conclude that the surgical proficiency could significantly affect the surgical outcome in the minimally invasive surgery. Another also Korean trial about the learning curve, they found that about 30 cases were required to achieve an acceptable 5-year disease-free survival rate in the open hysterectomy group versus 60 cases in the laparoscopic group. Also, they conclude that the surgeon proficiency affected survival in both groups when tumors were 2 centimeters. I'm stressing on this number, I'll explain later why. Indeed, a steady reduction in disease recurrence was directly correlated to the surgeon's experience. Another study by Reddy et al. To study the learning curve of laparoscopic radical hysterectomy after its implementation, they concluded that 23 cases were needed to improve the surgeon's proficiency. Similarly, Kong et al. Found that the oncologist could reach a level of surgical proficiency only after 20 cases of laparoscopic radical hysterectomy. And regarding the robotic radical hysterectomy, METAL concluded that their study that surgical proficiency can be achieved after 28 cases. So at least we found that most of them, they agree that you have to do at least 20 cases of laparoscopic hysterectomy to achieve a good skills so you can be efficient enough to do that number of cases. So why I'm stressing about these numbers, because we have some problems in maybe, okay, 2 minutes. خلاص باقي 2 slides. In Egypt, our problem in Egypt and in countries which have the same problem in Egypt, is this is our problem. This is mainly our problem. For our foreign guests to explain this comic, that when you ask someone to do you a favor, and he cannot, or a topic, and he's not trained to do this topic, or he didn't do this topic before. So instead of telling you that I cannot do this, or I'm not trained to do this, he told you, okay, I may try. If I try, maybe I can. So he tried to do this. So how many cases eligible for surgery done in each year in high volume centers in Egypt? Me, myself, I work in the oncology center at Mansour University, which is the second largest oncology center in Egypt. Last year, we had nearly about 100 cases of cervical cancer in the outpatient clinics. How many cases of these 100 patients were eligible for surgery? Only 20 cases. We did nearly 20 cases last year. So in the whole year, we did 20 cases, not all, of course, by the same surgeon. So how many surgeons in each center are performing this type of surgery? Are all the surgeons dedicated to this special subtyping, or the 20 cases are divided between Muhammad and Ahmed and Ali and. Most of our cases, our problem here in Egypt, we don't have a solid screening problem. We are not used to do a vaccination for our women. So most of our cases are locally advanced. So to find an early stage cervical cancer like stage 1A1 or 1A2, it's nearly impossible. I only saw once a stage 1A2 here in Egypt in all my life. Last year we did, I said in Oncology Center University about 20 cases. About 5 years ago, I was in Gemelli in Rome. They nearly did the 20 cases per month. So there's a big difference. So to speak about the learning curve between the multiple countries and multiple centers should be considered in your future design to do such cases, where you will do it by open technique or by minimally invasive technique. So to conclude, the oncologic safety of laparoscopic radical hysterectomy is still questionable to date, especially in tumors more than 2 centimeters. The learning curve of the acting surgeon significantly affects the oncologic outcome of such cases. In the absence of well-established training programs and such procedures with sufficient number of cases, it's better to avoid the minimally invasive surgeries. Before speaking about the oncologic safety, you had to be sure about the surgeon proficiency in such cases. And lastly, our goal is mainly better outcomes, both oncologic and surgical, whether by laparoscopy or by the open technique. And thank you all.